How's everybody doing today? Can you hear me okay? Excellent. It's a real pleasure to see you all, and I'm going to be talking a little bit about deep brain stimulation, which is a pacemaker technology for the brain, if you're not familiar with it. And first, just to highlight a little bit about why, I'm going to talk a moment about how Parkinson's affects the brain, which you've probably heard a little bit about already. Everybody probably at this point is familiar with or have heard of a Lewy body, which actually doesn't just have to do with Lewy body disease, but is the pathology that we see in Parkinson's. So if you look under a microscope, very, very small, neurons or brain cells have these in them, and that's what causes the problem in Parkinson's. And then if we look at an MRI or a picture of the brain like this is a kind of crosswise. These Lewy bodies accumulate in brain cells down here in the midbrain called substantia nigra that I've seen in some of the talks earlier today. These brain cells degenerate, they don't make enough dopamine, and as a result, the striatum and basal ganglia don't work properly. The good thing about all of this is that losing the dopamine that comes from that is one of the key things that causes those problems. If we replace dopamine, we can get things better. But also, if we can just get the basal ganglia to do what it's supposed to do, because when dopamine is lost, it just doesn't work right. It kind of slows down. We can use a pacemaker here as well to give you continuous benefit, very similar to what dopamine does, but it doesn't fluctuate. It doesn't require you to absorb medications either. And this is what deep brain stimulation does. And so one of the challenges why medications is not enough for everybody is in early Parkinson's, the levodopa works very well. This is just kind of a graph of what your response would be like over time. In average, an early patient, there's time, hours across the bottom, and the benefit is higher in the graph. And you have to be in this kind of window where you have enough response where you're good, not too much where you're having problems like dyskinesia. And for an example like this, in early PD, the medication keeps you in the window from dose to dose. What's maybe surprising is this red graph is actually what levodopa is doing in the bloodstream. It does not last that long. It only lasts about 90 minutes. The reason there's a difference between the two is your brain recycles the dopamine, and by recycling it, it's able to use it over and over again, so it lasts a lot longer than that and keeps it stable. But as the disease progresses, that benefit gets a little bit more like what it does in the bloodstream. And in more advanced patients, it pretty much mirrors it. So we have lots of different things, and you heard earlier today about different medical therapies to try to extend this and get the medication to last longer. But this is the challenge. It still works well. It just isn't as long or consistent. And so deep brain stimulation is one of these other options to give you continuous benefit and not have to just depend on this. My next slide, I don't know if it's advancing. If you can. And so here is that same circuit that I showed you, the basal ganglia. And the idea is the deep brain stimulation or pacemaker wire is a lot like a heart pacemaker, goes into the basal ganglia, in this case the subthalamic nucleus, and paces it and makes it work normally again as if you had normal levels of dopamine all the time. And so when we look at how we're evaluating people with Parkinson's disease, effectively people that have half their day in some cases without the medication working were entered in clinical trials. And you see this graph, this pie chart on the left. The blue is the off time for these patients, and the orange is the on time without dyskinesia. The teal is more on time with dyskinesia. So you got half your time off, a quarter of your time good where you're on without dyskinesia, and a quarter time that you're on but you have some dyskinesia. After 6 months of deep brain stimulation therapy, 3/4 of the time was on without dyskinesia. A little bit of what's left is actually with some dyskinesia, but much less, and a very small amount of off time. So it really stabilizes the symptoms over the day, gives you hours back to your day in total because of the stimulation. So who's a candidate? Somebody with typical Parkinson's disease, what we're talking about today. We do have other indications for other conditions. Originally, you should have a good response to carbidopa, levodopa, or Sinemet, with a small exception. And some of the major things that the pacemaker or DBS can do should be some of the things that are troubling you in order to get good results from it. So tremor, stiffness, slowness, dexterity, dyskinesia as well is something that responds very well. And no significant untreated depression, anxiety, or memory loss. We want these other kinds of problems to be optimized before you would consider an elective surgery. And so our thought process is making sure the diagnosis is right, really understanding what your goals are, what you expect to get from surgery, making sure it's something that we can deliver. Have medications been tried adequately first? And how do predictors of good and bad outcomes weigh? And so when medications are not enough for people, usually it's because despite dose adjustments, you're still having early wearing off between doses, frequent cycling between on and off. Tremor, in some cases, is stubborn and doesn't respond to the medication. This is the one exception where even though the medication doesn't work, DBS works very well on tremor as well, so that you don't have to have tremor if you have medication-responsive symptoms. But if you have bad tremor, this is a great option as well. And then also troublesome dyskinesia from the motor fluctuations on and off is also another reason why DBS may be chosen for some patients. So these are realistic expectations: improving tremor, dyskinesia, the ups and downs, and off time, longer lasting benefit through the day, improving the slowness. Some people get dystonic cramps or pain. It can help with that too, at least if it's levodopa related. And some reduction in medication, but that's not really the goal. The goal is to make you as good as you possibly can be. And improving off-period freezing. Freezing is tricky, but when you have it when you're wearing off and it gets better when you take your meds, that's a sign it may respond to DBS. Sometimes that changes over time, so it is very tricky. And a lot of people have freezing when their meds are working, and that does not typically respond to DBS. And so that's on my not realistic expectation list. Improving balance and memory or swallowing or bladder function are also regulated by other parts of our brain. We have other ways of managing that, but DBS does not help those symptoms either. So the big question that we always have is, what are your goals? And trying to make sure that if we're looking at this, that your goals are really aligned with what the therapy will do, and then you will be very happy with it. And what's most important, of course, is that you get what you anticipated. So if your goals aren't aligned, you're probably not going to be happy. What's the process? Multiple steps, but first starting with your movement disorders provider. We do medication response testing, look at how you are on and off meds. We want to know what your goals are, really have a deep discussion about that and how that's going to change after surgery. You'll see somebody from our neurosurgical team looking for surgical risk. And we do some memory or neuropsychological testing and MRI. All the testing that we order gets lumped together in our center, usually in 2 days, that we can schedule back to back and get done very quickly. And then a week or so after that, our team gets together. We all talk from all different angles about your condition so that we understand what we need to do, and we have the best approach that's tailored specifically to you. We have the right target because there's different choices, the right device for you and everything else. And then if you're going forward, then you get some pre-anesthesia testing just before surgery. They do an EKG and some blood work as they would with any surgical procedure. And then the surgery's done in a couple different stages. One for the brain surgery to put the pacemaker wire in, and then the battery in later. And if we do two sides, those are done separately. And then you come to our clinic about a month later for programming, and we turn it on, go through all the parameters, and then several visits after that to really optimize things over time. And just a final highlight here, there's a lot of new technology from the 3 different companies that we have. They're MRI compatible now. We have directional leads. You're going to hear in a moment from Shannon and Jim from Medtronic about sensing and some of the new technology that they have. These are the 3 different companies, Abbott, Boston, and Medtronic. They all have these directional leads, which allow us to really steer the current in the right area. And this is an example from the Boston Scientific system on how this is done on these 3 systems. And you can see we can move the current. This red ball is what it would look like, what the current field looks like, moving it up and down the pacemaker wires. We can go up and down, and we can also, you can see, kind of move it around in different directions, and that's the directionality of it. So we can basically fit that to your anatomy so that we have that effect right on this green target, which in this case is a subthalamic nucleus, right where we need it. So it's very important and elaborate to get these pacemaker wires in the right place, but the technology allows us to then fine-tune it afterwards and make sure it's perfect without side effects. There are rechargeable batteries from Boston and Medtronic currently. These last 15 years. And with the Abbott system, there's the availability for remote programming through a virtual visit. There's also another treatment that's available called MRI guided focus ultrasound. We also do that at the Cleveland Clinic. And this makes a little lesion in the brain without surgery, but it's still a brain procedure and currently works well on the tremor. They are working on some technologies to be able to do this for other Parkinson's symptoms, which are now approved, but we're waiting for insurance approval. And with that, I'm going to let Shannon and Jim tell you a little bit more in detail about what the experience is like with deep brain stimulation.
So good morning. I am Jim Adler with Medtronic. Go ahead.
Show a little video?
We're going to show a video just to try to articulate a little bit about what brain sensing can do, and a few slides that'll kind of articulate that, and then Shannon will discuss an individual patient's information and how we've used that to optimize Mark, and then Mark will be the main story here and how he is done with his journey with DBS.
Akinetic, rigid Parkinson's disease exhibits near normal mobility, brain signals may show moderate synchrony with minimal frequency peaks. When a person with Parkinson's disease experiences movement challenges, brain signals may be excessively synchronous with a peak at the beta frequency band. The Percept PC implantable system for deep brain stimulation from Medtronic is the only system that can chronically detect and measure signals from the brain. BrainSense lets clinicians capture these signals from the brain both during and between visits, and this personalized information, along with other clinical information, may be used to inform clinical decisions.
Great. So that video is meant to show a signal of interest called a frequency, a biomarker. When our animated friend there, Bob, when he was feeling off, you could see that signal was elevated. When he's in a better treatment state, when he's in the on state, you saw that signal was lowered and more suppressed. That's the point of the device, is meant to give the physicians and the nurses information about how the patient's doing, not only in the clinic, but also outside the clinic. So a few things that this device can do, and the sensing capability that we can do with this device, is give information inside the clinic during a programming session, for example, looking for that biomarker, seeing where that signal of interest might be. Where is it located on that brain electrode? Is it lower down the lead, or in the middle of the lead, or higher up the lead? That's all helpful information to program this device. Also in the programming clinic, Shannon has done this many times. You can take a patient's signal of interest, that biomarker, and we can live stream that signal in the clinic while the patient's being programmed and looking to see how that signal is responding to stimulation. How's it behaving? Is it getting better with stimulation? Is it getting worse with stimulation? So that's all information we've never had in the past that can give objective information to help program this device. And then outside the clinic, we can see how a patient's doing at home. And Dr. Walter talked about meds wearing off and when meds are working. Well, that's why you had DBS. We can see with this device how the meds are actually doing for the patient. So not only are we using it to measure stimulation, but we're also seeing how is the patient doing at home. And some of the information that we can glean can help give the nurse and the physician some additional information as to how to manage the medications that the patient's on. So it's not only in the beginning of the journey with the patient, but it's meant to help the patient and the nurse and the physician throughout the life of the journey with the patient's device. We can go through it. So I kind of motor through the slides. This is what the patient programmer looks like on the far right. The device is on the left. In the center is the clinician tablet. That's what's used to program the device. That's where we can live stream a patient's brain signals during a programming session. The patients can participate by marking events with their patient programmer, like when you take your medicine, when you're feeling good, if you have dyskinesia. When you do hit an event like that, the device will measure your signal, your biomarker, over a 30-second period. It'll give us a lot of information at that given moment. We can see all the frequencies of the brain that device can measure. And again, it's just to provide more information, another piece in the puzzle that can help optimize you with your DBS. So it's, again, this is all information we've just never been able to collect outside the clinic and while the patient's at home. Yep.
All right, so I'm going to take all that information those two guys just said and make it make sense now, okay? So I'm lucky enough to have one of my patients here that wanted to share his experience with everyone. So we'll call him Mark. That's actually his name. Diagnosed in 2016 with Parkinson's, but as many of you know, probably you tend to have symptoms way before. And when you look back, you're like, wait a second. So he feels that he actually had symptoms as early as 2003 before he realized what it was. Prior to DBS, Dr. Walter talked about wanting to know expectations and then what are the things that we can help with. Prior to DBS, his issues were severe motor fluctuations, that's the on-off, severe tremor, bradykinesia, and orofacial and head dyskinesias. So if anyone's ever had head dyskinesias, it's just where your head moves when you don't really want it to. The medications he took prior to DBS, he took the controlled release Sinemet, 1 tab 5 times a day, but that's a double strength compared to the normal Sinemet. So he had 5 times a day was taking 200 milligrams of Sinemet CR. Sinemet IR, he was taking 1 tablet along with the CR 5 times a day. Selegiline 5 milligrams daily, and Ambrosia as needed, 2 caps, and he could do it up to 5 times a day if needed. It's quite a bit of medication. This is Mark's video from DBS evaluation. So this is how he looked prior to having deep brain stimulation, and this would have been what he looked like when he was off his medications. So
I've had all my shots and everything.
sounds like
boosters and
we don't need audio. That's just my voice. This is just showing how difficult it was for him to walk. He almost falls over. That's why he has this lovely assistant with him. All of you probably, many of you can probably relate to how this feels, especially if you're out somewhere trying to walk. All right, so that was before he had deep brain stimulation. So he had his surgery. There's 3 stages. Dr. Walter kind of discussed that. These are the dates that he had his surgery, and then he came to see me in the office on June 20th, 2022, and that's where we turned his device on. So I'm going to show you just a little bit of the crazy technology that Medtronic can do and how it helps me dial in the programming. All right, so pretty much what these pictures are showing, when you see that big peak that's in all 3 of these pictures, those are symptoms. Think of that big spike as we are recording these symptoms from Mark's brain. So it shows on the first one that the signal is strongest when it's way high up. That's showing us where on the lead the signal is strongest, so that helps me know where I should program. The next one shows there's 4 contacts on each one of the leads. The second one's going to show me which contact is kind of sitting right in the sweet spot that we want to stimulate. And then the last one shows us which direction the symptom signal is coming from. So those 3 things all show me, hey, go in this direction in this spot and you might get him some symptom relief. So then after programming him, you watch to see how do those signal peaks improve. And this is the data that shows we were suppressing those signals, which is what we want to do. We want to get rid of those symptoms that we were recording in his brain. So this actually came from, I think about a couple months later after I had made a change. Then we can record this from his brain, and it shows that we are suppressing clearly a number of symptoms that were happening on that frequency. This is kind of just another illustration of what that does. This is when we can live stream his brain signals in front of me in the office. So on the far right, you can see these big red peaks. Those are, again, his symptoms. So his symptoms are very high right here. This down here, this line, is my electricity that I'm turning on. So as the electricity goes up, you see the symptoms have gone down. So the electricity, as I'm increasing it, is dampening out these symptoms, which you also want to make sure you're looking at the patient and seeing that that's actually happening in the person in front of you too. So that's one of the most important things. Make sure that this data is correlating with what's in front of you. And this is just kind of showing how this is when we first started the live stream. Symptoms were very significant, and at the end, he had a good period of time where those symptoms were being suppressed. This is, they were talking about how there's some ability when you're at home. This device is going to kind of track those same signals and see, are they under good control while you're at home living your everyday life? So this whole graph is a whole day in Mark's life at home, starting from midnight all the way through midnight the next day. As you can see those 2 circles, those little peaks that are happening, that's showing some off time. All of these other ones are showing how his symptoms are mostly controlled throughout the day. So that was really helpful to us because sometimes Mark would come in and say, oh, my afternoons are just, I'm hitting a wall, I feel terrible. And we could go back to some of these and show that there's something that's happening in the afternoon. Can we address it? If we can't address it with deep brain stimulation, we can address it with a medication adjustment. And so here's another one. So these are just 3 different days of Mark's that he was at home doing crazy things like cutting down trees and digging ponds, because that's what he does now. But there was periods of time where he ran out of steam. And here's another one. It all tended to be kind of in the afternoon and the evening for him. And all of these other little yellow hash marks, that's showing very well suppressed brain waves, which means that his symptoms were better as well. So, oh, you're going through this? Where's my, okay, this is Mark after DBS. So this picture is a picture of a pond he dug since he's had DBS. He's got some physical therapy work up there on one leg on top of a Bosu ball. And then can we play his video in the middle there? Which is one of the #1 stated goals I get from the male species is I want to keep playing golf, is what everyone always wants. So here's him playing golf. Do you want to do that slide? The one that I skipped over? Oh. All right, so, and we're lucky enough to have Mark with us. So Mark, come up here. A much better walk up that stair. So I just wanted to have Mark just say a couple things about what his experience was like coming through this process and how he's feeling with kind of how life has been since DBS. But most importantly, you know, was today representative of what a patient should expect and feel? So you tell him something.
Well, we all know we don't do good with stress, but so I'm not doing too bad for being up here trying to talk when I don't get in front of people and talk at all. But yeah, I'm having a lot of fun. When they asked me what was my goals, I was trying to think of something. Well, what do they want to hear out of me? I always want to use my life for good, don't we all? But when I said I just would love it if I could have one day that I felt normal, that maybe I had a chance to forget I even had this disease, wasn't focused on the battle 24/7 and she'd get a break. Is that too much to ask? That was the answer they was looking for. That's exactly why we do this. We want to have our lives as normal as we can. Every day I find myself just looking for what my new normal is and go working up from there. We don't have to just lay back and take what life gives us. We have opportunities. I got to race my Corvette again last weekend. I hard enough to blow the thing up. At 144 miles an hour. Been playing golf once a week, enjoying that, working around the house, going to church, being active, doing everything we want to do. Can I say anything but thank you?
That's perfect.
These people are awesome. My experience has been great. I'm looking forward to my best tomorrows being in front of me, not behind me. My best days are ahead of me, not behind me. Our best days can be what we want them to be. There's a way to get it done, and I look at this technology now and where I perceive that it's headed in the future, and there's a whole lot of reason for a whole lot of hope that the day's right around the corner that I'll be able to get up and forget I have this disease again, because this stuff will have the capability to look inside here and see what my needs are in a moment and make appropriate adjustments and give them all the information that they need and confirm, because it's not just about how I feel. For me, it's about how I function. My functionality tells me how I feel. If I'm functioning well, I feel great. Thank you for your time. Appreciate it.
Thank you. That was good. You did good.
If I can answer any questions,
What's that?
everybody has
Oh, that's
questions.
So same as with all the speakers, if anybody has questions for Mark, he's happy to talk to you afterwards. So you can come up and ask him questions about his experience, and same with the three of us. Feel free to ask us questions afterwards. But that concludes our surgical therapy talk. Again, as I've said after every single one, there's going to be an exercise session right next door in this room. There's food for lunch in the big room, tons of exhibitors that you can do fun things with, and enjoy.